and oxygen toxicity, in addition to ventilator-associated pneumonia, which is formerly called ventilator-acquired pneumonia. Other issue that can occur using mechanical ventilation is cardiovascular and renal complication. This is as a result of increase in intrathoracic pressure, leading to hypotension. And because of this hypotension, the patient may have acute renal shutdown, decrease in urine production. Gastrointestinal problem can also ensue in form of gastritis or ulcer formation. And malnutrition in mechanically ventilated patients is very common. Neuromuscular and psychological complications include ICU acquired weakness, DVT, that's vein thrombosis, and pressure complications like sleep deprivation, sedation, abnormality, delirium. Includes this occur leading to injury in various circumstances. Ventilated, develop ventilator-induced lung with primary lung diseases like acute lung injury or ARDS. Volume trauma and barotrauma. Damage to the lung occur as a result of repeated or overdistension of alveolar structures and excessive transpulmonary pressure, respectively, leading to the rupture. And this rupture leads to the air leak into the pleural space, resulting in pneumothorax. And if this track into the middle mediastinum, it results into continuous tissue cause subcutaneous emphysema. Generally speaking, occurs when transpulmonary pressure exceeds 30. Also occur when the transpulmonary pressure exceeds 50 centimeter of water. Bowel trauma always, leads to alveolar damage, leading to an increase in inflammatory cytokines in the lung, resulting into injuries. Systemic cytokine release with bacterial translocation are involved in the systemic inflammatory response. And if this is not checkmated, it will lead to advanced injury called pulmonary organ dysfunction, which have high mortality. Arterial trauma. This is a recurrent arterial reopening and collapsing of the under-recruited alveoli during ventilation, causing injury affecting surfactant functions. And this leads to collapse of the dependent portion of the lung and resulting into regional hypoxia. The incidence of atelectasis is increasing, especially in patients requiring prolonged assisted mechanical ventilation. The administration of high concentration of oxygen in the inspired air cause further increase in the incidence of atelectasis. Adequate humidification of the inspired gas, chest physiotherapy, proper suctioning, and hydration are essential in preventing and in the treatment of atelectasis. Bronchopulmonary or bronchoscopy rather should be performed if atelectasis does not improve with conservative measures. Oxygen toxicity. Oxygen concentration nearing 100% are what is generally used when a patient is placed on mechanical ventilator initially. But this should be titrated to a reasonable level that will prevent oxygen toxicity. Oxygen toxicity is as a result of the oxygen radicals like peroxide, hydroxy radicals, or hydrogen peroxide. Increased reactive oxygen species leads to inflammatory process, and this secondarily leads to tissue injury. depleting or depletion of cellular oxygen defense and cell death may occur. Now, that leads to the concept of lung protective ventilative strategy. Volume trauma and barotrauma are the most common cause of ventilator-associated lung injury, resulting from tidal volume setting that generate high or excessive high pressure. Mortality rate was very high, but prior to year, but then the mortality is still high, 40 to 50%. Lung protective ventilation strategies were implemented as a result of the ARDS network trial in year 2000. And it demonstrated that lung protection to about 22% from 40 to 75%. And these are some of the strategies that can be used to and in order to lung ventilation, predict, because it's always very difficult to weigh the patient that is critically. And in so doing, tidal volume is the volume of the patient breath measure in mils, mission of getting the predicted body weight. And evidence 6 to 8 mils per kg of tidal volume in a ventilated patient, so as to have the benefit of reducing the mortality. And in getting the patient estimated weight, you need to use what is called demispan. Demispan is measured with the arm stretched straight from the base of the middle finger to the sternal notch. This is the formula that we use. And let's use the male formula. Now, the male formula is 1.4 times demispan in centimeter plus 57.8. So if you want to get the height, you have to use this formula. And getting the formula, you get the estimated body weight of the patient. And to determine the tidal volume of that patient, you use 6 mils per kg. So in other words, you get the tidal volume that is commensurate to protection of the lungs. Problem that may ventilator or ventilation rather is what is referred to as a ventilator associated high, 25 to 70%. And the diagnosis of ventilator associated pneumonia is very crucial. And the first thing that happens is, first and foremost, the normal flora is what is usually culture, which is usually gram positive. But after 48 hours, then is the gram negative. Usually the pseudomonas about 60%, and for Staphylococcus aureus about 20%, but some need 20%. And this needs to be identified. There should be high index of suspicion. Now, how do you identify ventilator-associated pneumonia? Regular X-ray is one of the things that needs to be done in intensive care unit. And looking at the chest X infiltrates, and on clinical ground, you may be able to also find some, some findings. The laboratory test may still raise white blood cell count, and clinically, the patient may have purulent sputum, the oxygen saturation may be going down, they desaturate very fast, and there may be elevated body temperature. Like I said, in most cases, 60% of ventilator-associated pneumonia involve gram-negative bacilli, usually in form of Pseudomonas aeruginosa, but about 20% Staphylococcus, and there could be mixing infection. Sample can be taken using the endotracheal lavage. And the key to prevention of ventilator-associated pneumonia is what is referred to as 5 moments of hand washing. That means there should be regular hand washing plus what is called ventilation care bundle, which include elevation of the head of the bed to about regular assessment for weaning and vis-a-vis extubation. Prophylaxis for ulcer, that's a stress ulcer, prophylaxis for deep vein thrombosis, and thorough or regular oral hygiene. This has helped a lot in reducing ventilator-associated pneumonia. Now, let's talk about the weaning. Weaning is the process of getting the patient out of the mechanical support and with the aim of extubating the patient so that the patient can go back to normal way of life in time of respiration. And care needs to be taken in weaning a patient from mechanical ventilatory support, because too early wean may be very dangerous. It may include re-intubating the patient, and re-intubating patient has higher mortality compared to the primary intubation. However, the patient should not be left too long on the mechanical ventilation. Otherwise, the patient depends on mechanical ventilatory support. It is worth noting that weaning protocol is not 100% accurate in predicting the success of weaning and extubation. So you need to judge on so many parameters. One of the parameters you need to consider is looking at the respiratory rate of less than 25 breaths per minute, tidal volume of greater than 5 mils per kg, vital capacity of greater than 10 mils per kg, minute ventilation, respiration to tidal volume in liters less than 105 and 130 in an elderly patient. You should also have a good satisfactory oxygenation, looking at the ratio of the arterial postural pressure of oxygen to fraction of inspired oxygen, which should be greater than 200 millimeter of mercury. The hemodynamic stability must also be ensured. The patient should not depend on vasopressor. Adequate neurological assessment is very, very paramount. The patient should be arousable, and or the patient is awake. Cough and secretion should also be assessed using the endotracheal tube, to assess whether and stimulate cough reflex, and also the degree of secretion in the airway. If it is copious and voluminous, that may be too bad for the patient to win, or difficult to win a patient. However, risk criteria that can be used to win a patient using rapid shallow breathing index of less than 100 after 2 minutes. And that is, I say, using a in liter. So rapid shallow breathing index is very sensitive, the readiness of patient to be weaned, and is very sensitive, 0.87, but not very specific, 0.52. So generally speaking, there are different methods, intermittent mandatory ventilation, is 1, pressure support ventilation is 2, spontaneous intermittent mandatory ventilation. The patient are either a mandatory ventilator controlled breath or a spontaneous breath with or without pressure support. The original intent of SIMV was to let the breath, but of course to work during the spontaneous breath. So weaning is accomplished by increasing the number of mandatory breath, gradually increasing the workload of the respiratory muscle. And this should be done by 2 breaths every 1 to 2 hours. The patient adequate should be looked into to see whether it is adequate for patient to be weaned by this method. It's also worth noting that this method is not the best means of weaning a patient, but it's one of the options. The pressure support ventilation. All breaths are spontaneous and combined with enough pressure support to ensure that each breath generates a reasonable tidal volume. Pressure support lowers the breathing for the patient, and weaning is that's the pressure support. And this transfer is continued. Pressure support approaches about 5 to 6 centimeters of water. When the patient cannot tolerate this level of intubation, is usually level of ventilative support. Many studies, including meta-analysis, have shown that, have demonstrated that the pressure support mechanical ventilation compared with SIMV alone. But sometimes the pressure support ventilation can be used in conjunction with SIMV when the patient is weaned from mechanical ventilation. This combined mode is used especially when the patient is frail and when the patient have underlying chronic illnesses. The other method of weaning a patient is what is referred to as spontaneous breathing trial. This is the best method basically in our centers in this country. It is an attempt to gauge how the patient might do. This method is also referred to or called sink or swim trial. Either the patient survive by swimming to the riverbank or sink and goes to the bottom of the ocean. So the key is ventilatory support while oxygenation is spontaneous breathing trial is the use of TP's trial. Connected from the ventilator or tracheostomy to be sucked to a the same assessment can be made pressure mode, CPAP, while the patient a common method of assessing the patient ability to do the work of breathing by himself. Variation of this team include adding more amount of pressure and using a CPAP of about 5 centimeters water. Studies have shown do not require prolonged. This observation explains why spontaneous breathing trial is both useful and practical. At the end of the spontaneous breathing trial, the patient should be evaluated for possible extubation, considering the vital signs like the blood pressure, respiratory rate, heart rate, SpO2, and gas exchange. SBT should be performed only once. Like I said, several SBT per day does not actually bring out a good outcome by so many studies. Several SBT they offer no additional benefit when we compare to one SBT per day. Now, in doing the SBT, a patient can be weaned at first attempt, and in that case, it is called a simple weaning. When you do an SBT for the patient and you wean the patient, that means the patient can be extubated. And if the vital signs are stable after the extubation, without re-intubation, with the first attempt, the patient is sent to have a simple weaning. However, if the weaning process have to be done, as if the SBT have to be done twice or 3 times before the patient can be successfully weaned, that means the patient have a difficult weaning. But sometimes the weaning can be done more than 3 times or more than 7 days. In such cases, the patient is referred to as a prolonged weaning. And in doing the SBT, there are features, clinical features that you need to look out for to be sure that the weaning is actually successful. One, there should not be flaring of alar nasa. The patient shouldn't be cyanosed. There shouldn't be tachycardia, costa, supracosta, or supraclavicular recession, and abdominal paradox should not be present. Of course, if all these things are available, or some of these things are available, the patient needs to be reintubated and mechanically ventilated. So all patients receiving ventilatory support should be assessed on a daily basis for early detection of complication, for prompt intervention, as well as their suitability for weaning. This may involve meeting several preconditions and then an SBT. If unsuccessful, weaning should be attempted using either PSV or daily spontaneous breathing period for increasing duration. Non-invasive ventilation may be a best option in some patients, and tracheostomy may be an option. I want to say a few words with regards to what's supposed to be the ideal for a mechanical ventilatory support. One, the machine should be user-friendly, and it should be affordable, easily accessible, and it should have minimum or less interface that should be able to synchronize easily with the patient respiration. So thank you for the audience. I want to acknowledge both people, include all my teachers and mentors, and these are my references.
Thank you very much, Dr.
Thank you.
We're impressed with the discourse and the lecture you give it to us on the complications and weaning. I want to summary mention that complications that arise from the volume that is administered because of mechanical ventilation, from the pressure that is administered because of mechanical ventilation, and then the effect of these two on opening and then the closing of the alveoli. So the complications are from volume trauma, barotrauma, athletic trauma, and the fourth one is called biotrauma. Biotrauma, it comes as a result of the release of the cytokine.
Hello?
So these are, I'm giving a summary of what you presented, sir. And he also mentioned that as a way of protecting the lungs from these complications, he mentioned about the use of the lung protective strategies, which is a key thing in protecting and preventing the lungs from developing complications as well with mechanical ventilation. Talk about the use of a low air volume, which originated from the ARDS studies as far as 2000, about the use of the low tidal volume, 6 to 8 mils per kg, and how to use the predicted body weight using what they call the Demi span, which he mentioned as a way of reducing the volume and reducing the risk that the lungs are being subjected to because of mechanical ventilation. He also mentioned about other complications, which includes the ventilator-associated pneumonia. And he said once a patient is placed on mechanical ventilator for more than 48 hours, the patient is prone to ventilator-associated pneumonia, which initially could be as a result of the gram-positive organisms, but later on the gram-negative organisms now predominates. He also mentioned about how to identify ventilator-associated pneumonia, and then he listed the features that are associated with the ventilator-associated pneumonia. So once you assess the patient and you see any of these features, you can actually make a diagnosis of ventilator-associated pneumonia. He also mentioned on how to use the he also mentioned how to use the ventilation care bundles to prevent VAP, ventilator-associated pneumonia. And then with that, he talked about weaning, which is the process of getting the patient off the ventilating support. And he talked about the indications for weaning, some of the good cough reflex. There are many features that he mentioned. Good cough reflex, and then he mentioned the use of the rapid shallow breathing index, which can be used if it's less than 100 to identify a patient who is ready for weaning. He also talked about the use of the various modes, both like the synchronized intermittent mandatory volume ventilation mode, the pressure support modes, and then the spontaneous breathing trial using the
Must
TPs.
all please let me respond to the questions in the chat box.
I'm
Must
summarizing your
all
presentation,
these
sir.
features be present before we make diagnosis of VAP? No, the answer is no,
Excuse me, sir.
but there
Excuse
should
me, sir.
be high index of suspicion. We should know that when the patient is febrile, that means there's an infection going on somewhere, which may be ventilator-associated pneumonia or something else, but there should be high index of suspicion. X-ray is very paramount in this kind of patient. Then the next question is, please clarify frequency of suctioning and acid prophylaxis for relation with ventilator-associated pneumonia. Yeah, thank you very much. I don't know of a specific with suction as required because no two patients are the same. Some have excessive secretion, which if it is not regularly suctioned, it can actually lead to tenacious secretion and clogging of the endotracheal tube. And that is why it is very difficult to know endotracheal tube change on daily basis of the endotracheal tube produced. So some patients may have the using H2 receptor antagonist. You can use that. You can Okay, like I said, H2 receptor the patient. And the next question is, of all the method of weaning, which is the most commonly practiced and safest? Uh, Based on the lit in many centers in Nigeria, spontaneous breeding trial is the best, and based on meta-analysis that has been done worldwide. The next question is, what are the, sorry, that question I've gone. Then the next question is management of ventilator-acquired pneumonia. It has an holistic approach. At the early phase, what we do in most centers, or what is advocated, is that you should use a wide, broad spectrum antibiotics that covers both gram-negative and gram-positive organism. But after the sample, then you have to de-escalate, meaning you have to use a narrow spectrum antibiotics approach. Usually, like I said, more than 60% of cases is Pseudomonas. Then, thank you, sir. Please, is ventilator-acquired pneumonia the same as nosocomial infection? Any relationship between them? Yes, there is not the same. The nosocomial infection is the infection you acquire in an hospital, but ventilator-acquired pneumonia is specific. That is a pneumonia that resulted from the use of mechanical ventilation, and usually it is due to the presence of microorganisms in the airway. What is this? Okay, please, please, can I get the slide for? Okay, I think the, I don't know. I think so. Many thanks. Huh? Sorry, Abdul, I can't hear you. All right, let me proceed with the answers. Okay, so somebody is asking, what are the common cause of fighting the ventilator and way to prevent or manage this? By the when there is the ventilator and mention of synchrony, which is one of the most important things that the ventilator must have. So, but if there is asynchrony, they will be fighting of ventilator. In other words, the patient will be breathing against the setting of the mechanical ventilation. There won't be synchrony. Apart from that, when the patient is agitated, especially when the patient is not sedated, and the patient is aware of his environment, immediate environment, and wants to talk, and it's not possible because of the endotracheal tube. Sometimes when there is partial occlusion of ventilator or struggle to breathe, that is what is called fighting. And malnutrition in patient. Fat, and there are figures, and if you look at my references at the end of the presentation, there are so many ways in which patient can, have this problem. Is very, very common in them. Sometimes they are on NG tube and the feeding may not be adequate. Sometimes they are on NG tube only to decompress and is still ongoing. So when there's no food to metabolize or digest rather, the acid or pepsin endometrial lining of the stomach, leading to inflammation, nutrition because of inadequate intake, either via NG tube or through parenteral means. Please comment on the cough leak test done prior to extubation. Yes, it's one of the techniques that is being used for patients to be extubated. Even though if a patient passed the spontaneous breathing trial, you don't extubate, you deflate a little bit and see. I can't remember the precise pressure for now, I think about 130 or so. But then there is a relation to that. And if you are able to get above, I think 130, then the patient is good for extubation. Otherwise, you may continue on mechanical ventilation. This is about the last question on the chat box. Please, sir, what is the approximate nutrition for patient on mechanical ventilation? Well, I can't say precisely, but depends on how long the patient stay on mechanical ventilation. Like I said, once the conditions that warranted the administration of mechanical ventilation and wean the patient so that the patient doesn't become ventilator dependent. And nutrition is one of the crucial things that the patient needs to have for the patient to have to be ensured. And intravenous feed alone, and feeding the patient either enterally via the NG tube or via the parenteral means. Yes, that's the last question on the chat box.
Thank you very much, Dr. Gafar. Well done. That was an excellent lecture.
Okay, please, more light why SIMV is not ideal for winning. When you look at the three methods of winning, the first one I mentioned is SIMV, which is actually the least based on many meta-analysis. And the spontaneous breathing trial in many centers, and even the presence of what ventilation, is better than things to be synchronized with mechanical ventilation. Major problem with mechanical ventilator can also lead to complications. Probably that is that figures is not the ideal, Okay, somebody say winning. Yes, winning is a process of getting out of ventilatory support. And for you to win, you need to assess and reassess the patient on daily basis. And the vital sign, the cerebral function, the hemodynamics, and so on and so forth. You also have to look at the pathology that that initially warranted the use of mechanical ventilation. How long can a patient be on mechanical ventilation before considering tracheostomy? Yes, more often than not, we try to wean a patient from as early as possible. But in the past, it used to be any clinical condition that warranted mechanical ventilation of 10 days to 14 days or more. You should have a tracheostomy. But the modern concept is as need arises, because there are patients that you may think you will be able to win them within few days, and they may end up being ventilated for a longer period. So there's no hard and fast rule with regards to how long, but the general consensus is that for patients that have myasthenia gravis and sudden neuropathy or other condition of ARDS may be have tracheostomy. It's not easy to manage, and most people run away from tracheostomy means of ventilating a patient. Of course, if that is the only option that will benefit the patient, then you proceed. Somebody say on ETT. Well, the question is not complete, but maybe the patient means ETT. Okay. So it's a continuation of that question, you know. So initially is less invasive, means using a tracheostomy as using an endotracheal tube. But of course, like I said, if the patient needs to be ventilated for a longer period, maybe 7 days, 10 days or more, you may have to put the patient on tracheostomy. Relationship between ventilator-acquired pneumonia and nosocomial infection. Well, in a way, ventilator-acquired pneumonia may be a form of nosocomial infection, because nosocomial infection means hospital-acquired infection, but which is having infection from the use of mechanical ventilation. That's the last I can see on the chat box.
Thank you, Dr. Gafar. Well done. That has been a very excellent interactive lecture. I don't know where your moderator is now. Is Dr. Job around? Hello, Dr.
Yes,
Job?
ma'am.
Okay, yeah. Over to you, please. The lecture has been delivered and questions have been taken.
Thank you very much, Dr. Yunus. We are impressed. Thank you for the patience to answer the questions as it came. We can still avail everyone that wants to ask questions to go through the NSA platform and ask questions on the issues that have been raised in this discussion and even the previous ones. Ma, I think we should go over to the second part, which is on the exam-related questions.
Yes, please. Let's proceed. They were asked to drop in questions through the NSA email address. Can we find out from Dr. Okoje if there were any questions dropped for discussion? Dr. Okoje, please. We thank Dr. Gafar for the beautiful lecture and the questions. And we will proceed to the second part. But Dr. Gafar, please do not go far away. Your attention may still be needed to attend to some other questions that may come up. This section, we are going to ask those that have questions in relation to the ongoing postgraduate exams to bring it to our notice so that we can discuss it as we may be able to, or any other question as the case may be. So please, we welcome questions now or any questions that have been dropped earlier. We will also discuss them. Thank you very much.
The floor is open. You can unmute yourself and ask questions. Nkechi, please, over to you. Is there any question, please, Dr. Nkechi?
There's a question in the chat box from Dr. Namdi, but the question is not complete. Okay, I have seen the question now. The question says, please, how does one answer this question? What are the tests for a patient coming for lung resection? Hello, Dr. Nandi, can you please tell us, is this an exam question? Is it a part one question? Or is it for West Africa or national, or you're just curious to know the tests? Okay. Dr. Namdi says it's a part two question, orals. Okay. Thank you very much, Dr. Namdi. So let me read the question again. The question says, what are the tests for a patient coming for lung resection? And it's a question featured in the postgraduate exam part 2 oral. Please, can you mute yourself if you're not talking? Please, somebody is in a noisy place. Kindly mute yourself. So back to our question, Dr. Gafar, would you like to give us an answer to this question, or Dr. Job? The question is, what are the tests for a patient coming for lung resection? It's a part 2 oral question, part 2 fellowship exam, orals. Hello, our speaker for today, Dr. Gafar. Would you like to attempt the question? Dr. Job, Dr. Job is muted. Dr. Job, can you unmute yourself, please?
Yeah, it's muted now.
Hello, Dr. Nkechi, are you there?
I'm trying to reach the speaker. I don't know why it's not responding. Yes,
Okay,
ma'am. Yeah.
he has taken all his questions. We have a question on the floor. It's a part two question. It says, what are the tests for a patient coming for lung resection? And he says it's a part two oral question. There's another
Uh,
part one oral that is classified ventilators. So I'm just reaching out to the speaker to ask if himself or Dr. Job can attend to any of the two questions. That was what I was asking. And if there's
Yeah, I think Dr. Tueta is trying to say something.
okay. Oh, Dr. Eta, nice to
yes,
see you.
ma'am.
Oh, please, can you?
Yes, ma'am. Can I make a contribution? Okay.
Yes, go ahead. Throw some
Coming
light.
for lung resection, meaning that a portion of the lungs will be, or part of or the whole of the lung will be removed. So you want to do, apart from the routine test for surgery, you want to know whether the patient or you want to do resectability or operability test. For resectability, meaning that you want to know the extent of the pathology to determine whether you'll be able to resect the lungs properly intra-op. So things like CT scan and MRI are usually done to determine the resectability. But for the operability, which implies whether if the lung if the portion of the lung is taken off, whether the patient, what will be left, will be able to sustain and hence whether you'll be able to wean the patient from the ventilator. So things like lung function test, FEV1 is usually done, and then the carbon monoxide diffusion test, DLCO, is usually done. There is a calculation that I guess that's what the person is asking for, that to determine the resectability of the lung, it's involve a calculation that determine that you have to determine the portion of the functional lung that will be taken off together with the diseased lung as a proportional as a proportion of the total. I can't recall vividly the formula now, but it has a formula which the person has to check up. But that's, you have to determine that, otherwise you may not be able, what is left may not be able to, may not be the lung, the post-operatively, if you take off a portion of the lung that from the prediction, you saw that this patient, what will be left is the functional part of the lung is so small, and patient will not be able to be weaned off the ventilator. So you advise the patient against the surgery, but that resectability part is important and involve a simple formula which the person has to check up. That's what I can remember for now. And that's done in addition to, and this formula is related to the lung function, the FEV1 that is usually done.
Okay.
Thank you.
Dr. Etta, thank you very much. Can you hear me?
Yes.
I think also the number of segments to be resected is divided by the total number of segments, and this is multiplied by the FEV1 in the pre-op period. So whatever is gotten is like percentage. So usually, if the post-operative FEV1 is less than 40%, it's advised that the lungs that patient should not undergo the surgery. It is less than 40%, what to be left. So that is what usually done. The normal calculation number of segments over total number, number of segments over total number of segments times the pre-op FEV1. That will give you the pre-op FEV1 in the form of.
Yes, thank you very much, Dr. Koje. That is a very good addition. And even before you go deep into the carbon monoxide test and the resectability test, there are simple bedside tests of lung function that you have to start to do for patients that may have a lung collapse or destroyed lung syndrome. Simple things like breath holding tests of suppressors, like the matchstick tests. All those are things that help you to, like a prognostication, to actually find out if this patient can cope with the amount of lung function that is uh, remaining if the lung is resected. Even simple things as checking how long the patient can talk or make conversation before getting tired or breathless is also a simple bedside test that can be used at the bedside. Thank you very much for that. I hope Dr. Namdi is happy with that answer from about the question on the tests before a patient has undergoes lung resection. Of course, the general tests are also there. The usual things we do: chest X-ray, ECG, echo, depending on the age of the patient and if there is cardiovascular compromise, and then the regular things we do for liver function tests if indicated. Um, U&E, creatinine, full blood count and differentials, clotting profile, all those things are not specific for lung resection, but they are important. So, with that, I think we have attempted the question well enough. The candidate needs to go back and read up the topic very well and build up on it. These are just hints we are giving. So there's another question here. It's a beautiful question. Thank you very much for the question. The question is from Abdul Rahman Mohammed. It's asking everyone. It's a part one oral question. Classify ventilators. Classify ventilators. And the second question is, what are the anesthetic considerations in flap surgeries? Thank you very much. Hello, are we there? Can we have a volunteer to talk on this? Our two speakers on ventilators are here today, Dr. Job Otokola and Dr. Gafar Yunus. Please, can you attempt to discuss this question, classify ventilators? Thank you. Hello, Dr. Job. Please come on air and if you're there and discuss this issue relating to your topic. It says classify ventilators. Hello, if Dr. Job is not there, can anybody volunteer to attempt the question? Any of our lecturers and trainers that are on? I can see Dr. Elumelu has just joined us. Dr. Elumelu, would you like to discuss this question? Classify ventilators. Would you like to throw more light on it? Thank you. Hello? Hello, can you all hear me, please?
We can hear you, ma.
Okay, Dr. Osaheni is trying to respond in the chat box, but can he come on and talk about it live? Dr. Osaheni, are you there, please?
Dr. Osaheni, you can go ahead and answer the question. I've unmuted him. Okay.
Okay, Dr. Osaheni is not coming on.
No.
Okay, what he said in the chat box is he just jotted some things down. But what I can say for a question like this, it depends on if it's short answer question, if it's a list question, or if it's a discuss question. But usually, if you're to classify something, you need to define it first. You need to say what a mechanical ventilator is and what it is used for. And then you can go on ahead to talk about the classification based on different factors. Now, from what Dr. Osaheni put in the chat box, you can have a turbine type of ventilator or the pneumatic ventilator or a combination of both um, turbine and pneumatic. And then based on the type of pressure, you can have a positive pressure ventilators. Hello?
Yeah, hello, ma. Yes, that's both negative and positive pressure ventilators. Can you hear
Yes.
you, ma?
Yeah. So I'm just reading from what Dr. Saz put in the chat box. But if there's anybody who wants to discuss it in details, Dr. Tokwala, are you there, or Dr. Gafar? You gave us very extensive lectures on ventilators. Can you please classify ventilators for us? Thank you.
I don't think they are coming on. That's the problem. Okay, well, I think we can look at the functions of ventilators using where you can find them. You can say, okay, this is an IC, this is a CS ventilator, and again, you can classify them according to pressure, negative pressure ventilators, and then positive pressure ventilators. The negative pressure ventilators are usually the iron lung, the one that was used like a body wrap and a chest thrust during the polio epidemic. Can you hear me, ma? Can anybody hear me?
Yes, we are with you. We can hear you.
Okay. Then, of course, you have the body wrap, like a tortoise shell around the patient. All these were used during the polio epidemic. Then, but recently, we now have the positive pressure ventilators. And if I follow the lecture series, you can find that we have the pressure cycle ventilators. And that under the positive pressure, you have pressure cycles, time cycles, volume cycles, and of course the non-invasive positive pressure ventilation. All these are all classes of ventilation ventilators. You can also classify them according to how robust they are. Like the ICU ventilators are robust, while the theaters is just to ventilate. You don't have all those modes that you find in an ICU ventilator. So those are the additions that I could make. Dr. Joe Butu, the lecture would have been by giving us more, if there are more other types for us to know.
Okay, thank you very much, Dr. Nkechi. That was a very beautiful addition.
Thank you, ma'am.
There is another question on the chat box. If we can look at it, there are so many questions now. One question, okay, before we take the question on anesthetic considerations in flap surgery, there's an announcement that the speaker for next week is Dr. Tonia Onyeka, and the topic is the anesthetics and disaster management. After that, we will take a break for the West African College and National College exams until May. So that's the announcement for now. Then the next question, let's discuss anesthetic considerations in flap surgeries. While somebody is preparing to give us some answers, let's talk about this other question by Dr. Oji Jonah. He says, good afternoon, my teachers. Please, during CPR using AED and prompted to pause for analysis and possible shock, when I resume, will I start counting 30 chest compressions afresh? That's that. Then Dr. Saheni added that other classification of ventilators in non-invasive and invasive. Yes, we have taken that. Thank you, Dr. Saheni. There's another question from Dr. Shaibu Ibrahim. He says, good day all. Please, at what positions do we place HMEs, heat moisture exchangers, in the breathing circuit in COVID patients, apart from expiratory end and Y junction close to end of the endotracheal tube? Hello, can you hear me? This question from Dr. Ibrahim, he says, at what positions do we place HMEs in the breathing circuit in COVID patients, apart from expiratory end and Y junction close to end of ETT? And how is the placement different in the pediatric patient? Thank you. Then another question from Dr. Mbawike Nathan. He says an allegation of verbal and attempted physical assault was reported to your head of department by a nurse against your colleague, and you were invited to make an input. What will be your approach to resolving the issue? This is a part 2 question on conflict resolution. Thank you all for all these very beautiful and interesting questions. Please, let's go back to anesthetic considerations in flap surgeries. These flap surgeries is about bones and plastics, all those that do plastic surgery, anesthesia for plastic surgery. Can anybody give us a hint or a header on this? Anesthetic considerations for plastic surgery, specifically for flap surgeries. Please. Your input is needed, my people. Hello, so that I don't monopolize the discussion. Please, is anybody willing to give us a hint to discuss it? Dr. Gafar is back now. Hello, yes, Dr. Gafar.
I just called Dr. Gafar. Is with us. Yes.
Okay. So can he attempt to talk about anesthetic considerations for patients for flap surgeries? Hello? Please, Dr.
I think
Gafar, are you there?
Dr. Eka is trying to say something.
Okay, come on,
Okay,
Dr.
I'm
Eka,
not
please
trying to
come
say
on.
it just that
Okay. Oh, okay.
my microphone
Oh,
has been on, but let me attempt
okay.
to come in a little. Flap
Okay.
surgery has to do with when you are taking a tissue, you mobilize the tissue together with its blood supply to cover another area. It's just like grafting, but the difference is that you take the tissue together with its blood supply to the other area. So I think what to note here your main consideration is for the flap to be taken, because nothing should happen to the blood supply, since it's usually you can take skin together, including up to the muscle, to cover a certain area that is denuded and all that. So the blood supply is usually very crucial to maintain the flow. So you have preoperatively, you have to know the integrity of the vasculation of the flap area to be taken. And then also you want to rule out if this patient has diabetes or things that can cause risk factors for atherosclerosis that may impair blood supply should be optimized. And then at the area of that area that is to be covered, the flap, the area should be void of infection. The infection should have been treated and cleared of infection. Then anesthesia wise, you have to maintain your anesthesia such that the vitals are maintained. Sorry, preoperatively as well. You also have to treat anemia.
We're finishing. Yeah, I'll call it to find out the top. When I said it, I will turn in
Oh, Sahel, please, you're
Hello,
disturbing
please,
us.
can you mute yourself, please? Is that Dr. Seheni? Kindly mute yourself. Okay, thank you. Thank you very much, Dr. Tueta. You have given us the main things is the considerations have to start from pre-operatively. I think basically the surgeons will have to select their patients adequately to be sure that the site from which the donor, that's the flap, is to be taken is freely mobile and can get to where or can be juxtaposed with where it is to be reconstructed. Then the other thing about the site, so there has to be good, adequate perfusion or vascular supply for that area. And then another thing is that preoperatively, the patient's um, nutritional status has to be ensured. The patient should be in good nutritional status, and then the patient should be educated preoperatively. Is to be told, because some of these microvascular surgeries or flap surgeries, they can be flap ischemia, and there are many factors that cause flap ischemia. That is loss of blood supply. Loss of blood supply to the flap can cause it not to take. So um, you have to be careful, and you have to choose your patients, and then you have to be sure of the patient's status nutritionally and otherwise pre-operatively. And so the quantity of albumin in the body is very important, because the quantity of albumin has an inverse correlation with wound dehiscence or fistula or salivary leak or pleural effusion. Also, another thing to be considered is the preoperative fasting. It should be minimal. You are not to fast the patient for such a long time. So patients should be eligible. It should be such that post-operative patients can be eligible for oral intake within the short period of time. So they should be fasted for clear solids should be allowed up to 2 hours and clear fluids up to 6 hours before anesthesia. All patients that have major head and neck surgery with flaps and those with for breast reconstructive surgery should be adequately prepared regarding the journey. That means there should be a pre-operative counseling. The surgeon should counsel them, and the anesthetist too should do his own counseling. Should tell them about what to expect after the surgery, after the anesthesia, when they wake up from sleep. And the last but not the least is the choice of anesthesia for the flap surgery. This depends on the site of the flap. If it's a region that can be adequately um, uh, supplied by regional block, you may do a regional technique. But where the donor site is on a different region and the site of the reconstruction is at a different region, that may be a problem. However, most of the time, the surgeons take, if it's head and neck, they take flaps from the upper limb area or the chest or the back region. Hello, everybody.
Yeah, we
Hello.
can hear you, ma.
Hi,
Yeah.
we can
Okay.
hear you, ma.
So those are the things I can remember for now. So the person should not be a diabetic, and if it's a diabetic, the glycemic control um, should be checked very well, so that the patient does not develop wound dehiscence because of poor blood sugar control in the perioperative period. And if it's a diabetic patient, then the blood sugar level should be controlled throughout the surgery and afterwards, and it should not be higher than about 10 to 12 millimoles per liter. The blood sugar throughout the period. Tight control is advised. However, the particular regimen for controlling the blood sugar is not important, but the important thing is to make sure that the blood sugar does not go beyond 10 to 12 millimoles per liter in the perioperative period. Um, okay, I don't know about the types of anesthesia. There are so many things you can do. You can do TIVA. You can also do a full general anesthesia. You can do regional blocks, like I said. So it depends on, it has to be specific to the patient and the type of surgery. Then, of course, the patient needs adequate antibiotics. Periop antibiotics, pre-induction antibiotics should be given. People are talking about use of clindamycin, but that clindamycin may increase the risk of the recipient having surgical site infection. In my hospital, most of the time they use Rocephin, which is ceftriaxone, and then sometimes they make a combination of ampicillin and sulbactam or cefuroxime for the perioperative antibiotic. Uh, this is what I can say for now. Okay, let's not forget about early feeding. That means the patient should eat as early as possible, and then we should consider pain management. Intra and post-operative pain management is important. So you can give opioid sparing multimodal analgesia You can give NSAIDs and cyclooxygenase inhibitors. You can use paracetamol as a combination, which is if it's safe and effective and no contraindication, to reduce the amount of opioids that you need to give. For those ones that need flaps, you may need to give additional nerve blocks. Can consider the use of additional nerve blocks in addition to regional blocks like transversus abdominis plain block, that's TAB block. And then you can also use a catheter to inject the local anesthetic if it's a head and neck reconstructive surgery, such as when they do fibula harvest, when they harvest bone from the fibula for reconstruction. So that is my own take on this for now. I don't know if anybody has other things to add. I hope the person that asked the question has been on to get the answers. I noticed that Dr. Agu Edith has had her hand up for some time. Dr. Edith, you want to say something? I want to read some of the contributions to the flap surgery. Somebody said, can use of an inotrope help in the flap surgery to ensure adequate perfusion? Another person said pain control should be considered too. Yes, I've discussed pain control. Somebody talked about the problem of prolonged surgery, positioning of the patient depending on the site, then antibiotics to prevent infection. Yes, thank you for the talk on positioning. I have discussed antibiotics also. Thank you very much. Okay, Dr. Abdurrahman Mohammed, are you there? I hope you are good. Thank you. So before we take the next question, let's hear the comment from Dr. Edith. Hello, Dr. Edith. Okay,
Yes,
Dr.
ma. Good
Abdurrahman, thank
afternoon.
you. Yes, Dr. Edith, please go on.
Okay, I wanted to add something that somebody has already added, that there could be positional changes, so the anesthetic should be aware of it. Also, that there is also risk of flap failure. So if you do not choose your patient very well, select the patient very well, the flap may fail. Then there's also a problem of prolonged surgery, like somebody have already mentioned. So it should also be anesthetic consideration for that. And then there's also issue of blood loss. So there should be adequate grouping and cross-matching, and blood should be made available for the surgery. Thank you, ma'am.
Thank you very much, Dr. Edith Agu, for that excellent contribution. I want to also add that Dr. Gideon Akafa added a comment on the chat box that prevention of hypothermia is very important. Yes, thank you very much, Dr. Akafa. The hypothermia may be a problem because of the large surface area might be exposed for long periods of surgery while creating the flap and putting it in the place it's supposed to be. So thank you for that. I hope we have all taken note of the things we have said and the contributions so far. I think we have discussed this issue for a good time. Let's move on to the next question, please, if we don't mind. The question is by Dr. Oji Jonah. He says that during CPR using AED and prompted to pause for analysis and possible shock, when I resume, will I start counting 30 chest compressions afresh? Thanks. Can we have responses from the audience? This is about CPR using AED. How do we go on? How do we process? Well, I mean, progress. After each time, we have to check the patient to see the progress or the response to our CPR. Do we start counting 30 chest compressions afresh? That's the question by Dr. Jonah. Your responses, please. Hello. Is there anybody that wants to attempt it?
I hear you, ma.
Yeah, Dr. Beckley, do you want to say anything? Dr. Odigbo, you are on. Do you want to say anything regarding this question? Dr. Lawal, can you throw some light about CPR and AEDs? Hello, sir, Dr. Lawal, Bode Lawal. Can you please throw some light on CPR and AEDs?
I don't think they are on. They are not.
Okay, I saw them. Dr. Lawal is
Hello.
on. Hello,
Yeah,
Dr. Lawal. Yes.
Hello, everyone.
Good afternoon, sir. Good evening.
Afternoon. Good evening, everybody. Cardiopulmonary resuscitation. We have the basic, we have the advanced, and I think we'll talk about basic life support because that is the one in which we use the AED. And basically, cardiopulmonary resuscitation has to do with re-establishing circulation of a patient that has suffered a cardiac arrest, and the patient is not expected to be of a terminal condition. So cardiopulmonary resuscitation, as the latest guideline, has to do with early onset of external cardiac massage. And then we have to really push hard and push fast. And it has to be continuous because our recommendation now is that we don't want to wait in between trying to auscultate or do anything. You need to go on until ROSC is established. And then the ratio of ECM to ventilation has to do with whether you have one restorer or two. So we use AED when we are doing basic life support. That's the only equipment that is allowed because basic life support actually is supposed to be what you can do with your bare hands and with your hands anywhere, anytime it occurred. But AED too should be available in every public place in clients that are resuscitation conscious. So we call for AED, and when the AED comes, it comes with its electrodes. So we have to, it's actually, it's an external defibrillator. So it's automated external defibrillator. So that will make us understand it better. So it comes with the electrodes and you place it one below the nipple and the other on the right side of the sternum below the clavicle. So the AED is an automated machine. So once you apply it and put it on, it will automatically prompt you on what to do. It's going to analyze the rhythm of the heart, and then if there is need to give shock, it's going to give, it will tell you give shock, and then you press for delivery of the shock, and then you continue with the CPR. Thank you. Thank you, everyone.
Bike.
Thank you very much, sir.
Thank you very much, Dr. Lawal. We're very grateful. That was a very good impromptu addition, and you have nailed it. You have talked about the topic excellently well. We really appreciate your input and your support. Bravo. And we'd like to ask Dr. Jonah, who asked the question. I hope you're satisfied. You should know that.
I think he was trying to. Mama.
Yes, dear.
He was trying to find out if it's going to continue how long it's going to continue the CPR just after the AED have said the shock is not shockable. He was trying to find out if when I has used the AED, how long is it going to continue CPR? So I think if you look at the Resuscitation UK, their guidelines, you are meant to continue CPR for 2 minutes before going ahead. After the AED has said it's not shockable, continue CPR. You do that for another 2 minutes before you put on the AED again to see if you can reanalyze the shock. Yes.
Okay.
You should do that for 2 minutes. That's the recommended guideline using the Resuscitation UK 2015. Yes.
Yeah, so he will still count the 30 chest compressions.
Yes. And he does that for 5 cycles before he goes back again to the AED. They expect that at least you should have 5 cycles of CPR within that 2 minutes before checking the AED again. Second time. So it continues just like that, yes.
Thank you very much for that. I would like all of us to go back and look at the European Resuscitation Council guidelines because there have been some modifications recently, 2020. So, but basically, yes, if you're using the AED, you have to, after you do the shock, you have to go back to CPR and start with your chest compressions as usual, as before. Thank you very much for that. So we still have some questions that we have not answered. We have about 3 questions we've not answered. We have the question on the heat moisture exchangers. Please, at what positions do we place heat moisture exchangers in the breathing circuit in COVID patients apart from the respiratory end and junction end and Y junction close to the ETT? And then how is the placement different in pediatric patients? Hello, please, some people should mute themselves. Hello, if you're not speaking, kindly mute yourself. There is some discussion in the background. Thank you. Okay, thank you. So the other question is an allegation of verbal assault and physical assault has been labeled against a doctor by a nurse. How do you do the conflict resolution? Then there's another question about okay, the other one is the contribution to the AED use. That is by Bosede Petrus. She said we should start 30 to 2 again and go for 2 minutes before checking for rhythm or ROSC. So thank you very much. Return of circulation. Okay, thank you for that. So we just have 2 questions to discuss: HMEs and conflict resolution. We have just 13 minutes left. Is there anybody who is going to throw light on the HMEs? And then we can talk about the conflict resolution, please. Hello? Hello, my beautiful people. I don't want to monopolize the discussion. Please, can someone contribute on the HMEs? What position do we place the HMEs? I might have to call some people to make some input. Please, if I call you, just try and contribute. Dr. Etta, are you still there? Can you talk to us about HMEs? There's another question from Dr. Obilo. How will you set up an ICU in a hospital? It's a part 2 oral question. So, Dr. Damboy, do you want to tell us about the HMEs? Dr. Ayodeji Damboy. Can you tell us about the HMEs? Hello? What about Dr. Hamisu Yakubu? Can you please tell us about the HMEs, I mean, sorry. Hello? Are we all there? Okay, Dr. Obilot says, how will you set up a recovery room in your hospital? Okay, part 2 oral, recovery room. Okay, sorry, I thought it was an ICU. I'm used to asking about ICU. All right, okay, good. That's a good question, but let's talk about our HMEs. While we are getting somebody to talk about the HMEs, let me talk about the conflict resolution. A colleague has been, there's an allegation of verbal assault. How do you approach the resolution of the conflict? A nurse has alleged that a doctor tried to assault her verbally and physically, and we are asked to make input. How do we resolve the conflict? Can we have inputs from the house? Hello, please. Okay, well, the general thing about conflict is that, well, in the hospital setting, it is common to have difficulties between different groups of people, and what to do. The first thing is this person is being asked to make an input. So the first thing is, do not take sides. Do not jump to the defense. Maybe the doctor is your brother or is your friend, or you work together, or the nurse is your friend or your whatever, and you take sides. You take one side or the other. Do not take sides. So be neutral as much as possible. Second thing is, do not point accusing fingers. Do not, maybe when you're talking to the person, you say, you, this one did this, you, this one did that. You're not supposed to do that. Then when you're asked to make your input, you will say, you will suggest that the people that are in conflict should explain themselves, to explain what happened, and you try to listen to them dispassionately without interjecting or anything. You allow them to tell their stories. And then, if you're asked to make your input as a third person or a bystander or a witness, use statements with I. Say, I noticed that, or I saw that. Don't be verbose and don't be vague. And then, as much as possible, maintain a calm tone. Even at the face of extreme provocation, or even if the aggrieved parties start shouting at one another, don't shout back and say, you keep quiet while I'm talking, or something like that. No, you maintain a calm tone, and continue to be calm throughout the period. Another tip or another suggestion is that you don't talk behind people's backs. If the people that have been involved in the conflict are available, try to bring them close, or try to bring them together as much as possible to talk while everybody is there, rather than this one says a conflicting story, this one says another story behind the other person's back. And then show a willingness to compromise or to collaborate. In conflicts, nobody can be right all the time. You try to meet each other halfway. Every person, both the aggrieved and the aggressor, should be asked to cooperate, to collaborate, to shift their positions a little bit until they can get closer to resolving the conflict. And then another thing, don't take it personal and don't take it, don't make anything personal. Don't own it or make it, for example, this one is a doctor nurse thing. Don't make it a Johesu issue, as what is happening in our hospitals now. Don't make it that, yes, you nurses, you're always like this. Can you imagine? Or then those other ones we talk about the doctors. Yes, these doctors, they're always very bossy, always very rude. That's how this one did the other day, and that's how Dr. X did 2 weeks ago. Let's avoid such references as much as possible. Be fair and be straight to the point. Don't digress. Don't join issues with another issue. Don't bring up other old issues or related issues or set some precedences. So those are my. There is no hard and fast rule about conflict resolution. You do what works for you, and you do what is socio-culturally right, and also depending on the religions, because Nigeria is a very religious society. Do what works for you and what is acceptable socially, culturally, and according to the dictates of the religions that might be put in play. As much as possible, don't change it into a church thing or a mosque thing or any. As much as possible, be be unbiased, be an unbiased umpire, and don't take sides. But also, some people will say, okay, now we have made peace, come and hug each other. It may not be culturally acceptable for a lady to hug the other person because they've made peace. Some will even say, yes, yes, now there's peace. Smile now and shake hands. It may not be culturally acceptable in some cultures or religions for the people to shake hands. So you don't have to impose what may not work for them. So the important thing, manage your emotion. Do not take anything to be one-sided. Make compromise and be willing to concede something in exchange for the other party's concession. Thank you very much. I don't know if there are any comments on that, on the
Yes.
conflict resolution. Yes,
Can I
go.
add something, ma'am?
Yes, please go ahead.
Okay. If a nurse reports to me that there's physical or verbal assault between from the doctor, I will, because it's a serious offense. I think it attracts some form of sanction according to the civil service rule. So I want to tell the nurse to put it in writing, because people do change. She could tell you one thing, and then when you call the doctor to hear his own side, her statement may change. So I'll tell her to put it in writing so that I have a written document of her story. Then then to the doctor, I'll call I may also issue a tell the doctor to explain, or I can demand the explanation by way of a query that the person has been accused of assault in the department. Kindly explain within 24 hours why it shouldn't be sanctioned appropriate according to civil service rule. So the doctor will also explain, you being the arbiter, kind of, you read the two sides, because usually when people are documenting what happened, they tend to be more honest, knowing that that document will not be changed, and it will be taken against them. So they will they will tend to tell you the true story when they write it. So when you having gone through in both sides, you now call them. If it's possible, you call them together for a meeting, because by that time you will have been able to look at the situation, what happened, and you decide um, the person who was at what really happened. So now you now call them to hear verbally, and then that's when you begin to ask further questions to actually know what happened. Then at the end of it, you may be able to, if somebody was actually at fault, if it's true the doctor pleads guilty that he was at fault, it's still it's still the prerogative of the arbiter to either impose a sanction or forgive or demand apology and all that. So I'll ask, in summary, I'll ask for a written document because it's serious. Then if it can be resolved on my table, I make peace and appropriate apologies be tendered. If it cannot be resolved at my table, then you push it over. If apologies cannot be resolved, you push it over to the next level of authority in the institution. That's the way I will approach it.
Thank you very much, Dr. Eta. Thank you very much. Well, some comments have arisen from your approach. Somebody has said this is more of conflict escalation than
Okay.
resolution. Conflict resolution is to make peace without damages. Dr. Bode Lawal, thank you, sir. Actually, even though it's a serious infraction, I will not start with writing of query, and I will not start with asking people to make a statement. Making statements are official things that maybe when you do go to the police and the police are taking up the case, then the police say, okay, now come and make your statement, write what happened, you write, and the other person writes, something like that. But that is a much more a more higher level of doing things. That such a thing is an allegation of verbal and attempted physical um, assault. So, an allegation is an allegation until proven otherwise, until you confirm it. Maybe you have to get any witnesses, any eyewitnesses, anybody that was there to find out what really happened. That's why I said there should be a discussion. Yeah, and then if you somebody said, I think a written document may or may not be escalated to the next level. However, it shows that the matter is being taken seriously. Yes, I agree. Well, it depends. It depends on where you are and your environment. That's why I said that there's no hard and fast rule. You do what works for you. You do what is culturally acceptable and what is practicable in your place of work or the institution where you work. And then it depends on what you are to the persons. So now, if you're the head of department, it's okay if you say you make your write up, but you cannot ask a nurse who is not working under you to make their write-up. The nurses work under the nursing services department or division. So anything you want to ask the nurses to do, you have to go through the nurses head of department. That is why professionally and in practice, I find asking people to write things causing more difficulty, because if you want to go, let's say it happened in theater, and you want to tell the head nurse in the theater, see what the nurse said my doctor did, please let's resolve it. The nurse can say, no, 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 we must take it off, let's go to the director of nursing services, which, if you didn't ask for a write up, you can quickly say, please, let's discuss it. Let's find a way. We are colleagues, we are brothers and sisters. Let's find a way to resolve this issue. And dispassionately, but with a lot of concern and empathy, solve the problem. Prevention, I agree. Somebody said prevention is better than cure. It's more, it's a major component. So, and Nkechi says that, that's Dr. Koje says that prevention involves role definition, duties of each team member, and protocols well defined, good communication, departmental planning, and lines of communications. Yes, thank you. I agree with that. But now, the discussion is that an infraction has happened already. But I agree with you that prevention usually is better than cure. So we have talked about this for over 10 minutes. I want us to move on, take the last question, and then close. We have overshot our time by 5 minutes. And as we're closing, let's remember to pay our NSA dues. Let the account details be pasted for members to see on the chat group, please. And also, let us remember the next session will be by Dr. Tonya Onyeka. And after that, we take a break for 1 month. Now, the last question is about the HMEs. Has anybody attempted to answer the HME question? Hello?
Dr. Luca Yode of Padola tried to answer the question.
Okay.
So the HME can be placed in between the circuit and the endotracheal tube at the expiratory end of the ventilator to prevent contamination. That's the contribution from Dr. Opadola.
Okay, thank you very much, Dr. Opadola, for that contribution. I hope that the person who asked the question, Dr. Shaibu Ibrahim, I hope you're happy about the answer. Thank you very much. We have pasted the account details for NSA on the chat box. Please, members, kindly try to pay your dues. I think it's 5,000. Hello? Members pay their dues, 5,000 for residents, 10,000 for consultants. Live membership is 100,000 naira. Please, the dues are the main, and you can pay online also on the website. Please, the dues are the main source of our income for running these things and running facilities and the association. Kindly help us to pay. Also, be informed that we had waived the levy for defaulters. That is, if you don't pay in the current year, you don't have to pay double the next year. But if we see the response, we may have to put back the levy as was the practice in the past. So kindly enjoy the period of, is it grace or so? How do we call it? And pay for 2021 in 2021 so that you don't have to pay a levy at the time you want to pay. Thank you very much for your time. Thank you for joining us. We want to take our photographs now. We want to take our screenshots before the many participants leave. We were 160 about 30 minutes ago. Now it's just 112 participants. Please, let's take the screenshots. The page that you put on your camera. Can we put on our cameras? And the page which we appear, we take it and hello. So let's have our camera, Dr. Grace, Dr. Gundeji, Dr. Ajani. Dr. Biseson, Dr. Yakubu Hamisu. Can we have our cameras on? So thank you, Dr. Bosede Petrus. Nice to see you. I saw your comment. Dr. Efe Douglas.
Thank you, ma'am.
Thank you for coming. I hope you join us next week. Please pay your dues.
Thank you, ma'am.
Thank you very much. If you can put on your camera, you can actually take your own page and paste it and put it up. Dr. Safiriu, Dr. Oyebola, let's take your page. Mbawike Nathan, your picture is upside down. Okay, no, okay, better now. So let's take it. Nice to see all of you. I'm so happy that many people are participating and you're able to stay till the end. Please continue. And I hope you can let us know what we are doing right. Let us know if the topic is okay for you. You let us know so that we can do better. Dr. Akindele, nice to have you on. You're driving.
Thank you, ma'am.
That's multitasking.
Thank you very much, ma'am.
Thanks so much. It's been good to have all of you. Please, if I didn't capture your page, kindly take your own picture and just paste it on the WhatsApp group. It helps to encourage people when people know that so many people can attend and benefit from it. Next time, when they see your face, next time they will join. They say, how do I join that your nice photograph? Dr. Obazie, how are you, sir? Dr. Emma, nice to see you. Dr. Obilo, I liked your question. Did we answer your question?
It was well answered.
Did we answer your question on recovery room? Did you answer your question on setting up of recovery room?
No, it wasn't.
Oh dear. It's because of our time. We are already after 5. But basically, setting up questions are an integral part of part 2 questions. You can be asked setting up of intensive care unit, recovery room, pain clinic, post-op pain management, labor ward, obstetric anesthesia, and so on. The basic thing to do there is the feasibility study. First of all, find out what you need. Do a background. Is it really needed? And then if it's needed, what are the things you need? Usually the important thing is the manpower, the materials, and the infrastructure that you need for the whatever you're asked to set up. So usually manpower for is doctors and nurses that are specially trained in that field, and for the materials you need equipment. For a recovery room is the basic things you need for monitoring, oxygen therapy, pain control post-operatively in the initial few minutes. So you must define what facility you have been asked to set up. You must say what it is. If you're asked to set up an ICU, don't go and start talking about recovery room or pain clinic. You must define what facility you have been asked to to set up. Is it an ICU? Is it a pain clinic? What is it? What function does it serve? Who runs it? And all that. Then you now talk about the infrastructure. Infrastructure covers the buildings. Do you have a purpose-built unit, or do you just improvise? For example, you may be asked to set up a day case anesthesia unit. Okay, so you should be able to say what is day case surgery, what's a day case anesthesia unit, what are the different types, and then who runs it, what kind of patients do you attend to in the unit, and the materials you need for the unit, how will you run the services, and so on and so forth. So I've run through not just ICU, I've told you about pain clinic, recovery room, daycare, daycase, ambulatory anesthesia unit, and all that. So you just fill in the gap. Then you need to read it up, okay? Check the relevant textbooks and be sure that you have all your information at your fingertips and be organized. Don't start at the end. Start at the beginning with definitions, with background, and the justification. Why do you need this kind of unit and all that? So thank you very much. I have to sign off now. It's 5:15. I don't know. Any comments? Are there any comments from our? Are there any comments from our moderator, NSA secretary, and the speaker of today, Dr. Baffa? I can see you.
No, ma, no comments, ma. Thank you very much, ma.
Okay, thank you. Thank you. I've started, some people have started paying their dues. Thank you very much for the prompt response. Okay, so in the absence of any other discussions, we'll call it a day, and see you again next week, same time, same station. There have been some comments about the timing. So when we start the next batch, we will consider timing or date change. Let's know what you think next time. So bye for now. Thank you and God bless. Bye.
Thank you, ma.
Thank you, ma. God bless you, ma.
Yeah, bye. Thank you, Dr. Shoyemi. Nice to see you again.
Thank you very much, ma.
All right, thank you. So we can end the meeting. Thank you. Bye.
Thank you, ma.
Thank you, ma.